Hello, good evening, good afternoon, good night, wherever you're watching me from. I'm just making this video because of some of my colleagues that will be taking their OSCE exam. Just doing this OSCE for them. This is to help them with their A to E assessments. What is an assessment tool used to observe a deteriorating patient, or when a patient was newly admitted in the hospital. A to E assessment is a framework according to Royal College of Nursing. It is an assessment, a framework. Today, I'm going to be showing you how you have to start. There are different types of OSCE. There are medication. There are a lot of other ways. But my own now, I'm focusing on A to E or A to G. And this stands for A for airways, B for breathing, C for circulation, D for disability, E for exposure. Then F is family, G for goals. So this examination comes in three parts: you, patient, and the examiner. So you have to be asking the examiner some questions. Then you'll be doing the physical observation on the patient. That's how it starts. Then, when you come in, you check the safety of the environment and ask examiner, is there any hazard? And secondly, the examiner will definitely answer you if there is or not. If there is a hazard, you need to sort out the hazard before proceeding. Then you have to come in and ask if the patient is well or unwell. You ask the examiner, he will tell you. And if he tells you he's unwell or unwell, whichever one, you still have to carry out the assessment. Then you will introduce yourself. Hello, my name is so dash dash dash. Then you ask for the consent. This is the very crucial aspect of it, because you have to make sure you gain consent before any caregiving. Then you also ask the examiner if the patient has consented. That's when you have somebody who cannot speak for themselves. Then you now identify your patient by checking the patient's wristband, making sure it's the right patient, because some people have the same name, first name, surname. So you have to know them and differentiate them, maybe either by their date of birth. Okay. Then you now ask if the patient has any allergies that they are aware of. They'll be able to tell you. If they don't have any allergy, you proceed. You maintain the dignity and their privacy, not in on the door. Draw the curtains if they need be, so that the other people will not see them. When you finish that, then you have to go back and do your personal care, like washing your hand hygiene. According to our former Prime Minister, he says you can wash your hand for 20 seconds by singing a birthday song back to yourself. That's it. Then now this is now when you now gain more consent to tell the patient that you are going to do A to E assessments for the patient to be aware. You start by checking the airway, making sure that the patient will speak full sentences. And if there is no visible obstruction or audible sound that could have any problem with the lungs. So if there is none, You still have to check if any intervention that you will use. Check any intervention that you will use. This could be by using a yankee to suction out any issues within the lungs. From there, you go ahead to check the respiratory rate. That's the breathing. You check the respiratory rate for 1 whole minute. That's when you check out the normal respiratory rate will be from 12 to 18 upwards. So you check it how many breaths per minute, and check the oxygen saturation by using the oximeter. The normal oxygen level is 94 to 100% for normal healthy patient. Then for people with asthma or COPD, it is 88 to 92% on air. If they need oxygen, then you will know. So, but when the oxygen level is low, below those numbers, you now have to administer 2 liters of oxygen to the patient. Then you will also be able to check the auscultate anterior chest process by checking the landmarks, 8 landmarks of the body. I'll be showing this video physically on how you will check it towards the front side and the back side. After that, you move towards to circulation. Circulation, that's where you check your blood pressure. You get your blood pressure equipment, put it on your arm, upper arm, very close before your elbow. You put your 2 fingers to make sure that it's not too loose or too tight, and making sure that the arterial line is showing. Then you check you ask what the blood pressure is, and that is between the radial artery from the lower thumb down upper to the center of your elbow towards your brachial artery. Okay, yeah. Then you now also check the heart rate, volume, and the regularity for 1 minute. Your heart rate is when you put your 2 fingers just below your thumb for 1 minute. You ask the examiner, they will tell you what the heart rate is. Then remember, you will have to bring out your new score chart where you'll be recording. For example, they could tell you that the breathing rate is 15. They will tell you the blood pressure is 150/80. They could also go ahead and tell you the heart rate is 120. So you record all those things to know your news score later. Then you have to check the capillary refill time, which is for 5 seconds. You press your finger on you press your big thumb on your finger for 5 seconds and release it to be able to tell you how many seconds, 2 seconds or 3 seconds, that it came back. Then move down to disability. Disability is when you check the level of ACVPU, alert, consciousness, verbal, pain, and unresponsive. You do this by asking 3 oriented questions to the patient, like for example, patient's name, date of birth, and where the patient I can ask the patient, where are you? Where do you think you are? Or those questions. Then when you move down, you check the patient's sugar level, BM. It could be like 5, depending on the number they will give you. You know that anything below 10, anything 4 to 10 is okay. And when it's above or lower than 4 or higher than 10, then that's when you will need to address the issue. So you travel again to check the patient's pain score. And when you're checking the pain, you have to use PQRST to check. The P stands for what provoked the pain, Q stands for quality of the pain and the regions where the pain is coming from, and the severity of the pain, like on a 0 to 10 or a 0 to 3, how will you rate it? And the time this pain is happening. Is it now or yesterday or how? So you also now ask the patient's mobility. If the patient is able to walk, or if the patient has had any risk of fall. You ask examiner all these questions, and whatever answer he gives to you, you will be recording your own answers, because you're going to use it when you're going to escalate to the doctor. So now you go to exposure. That's where the temperature comes in. Near you, we know that temperature is 36 to 37.7. Whenever that is higher, then it becomes an issue. Like 38, you know that infection sepsis is triggering in. Then you check the skin integrity. If there is any broken skin, if there is any damage, if there is any cuts, or if there is any pressure sore on the sacrum area, you have to check all these things. Make sure you still get consent before you could touch patient's skin. It's really important. And when you finish all this, you now calculate your new score. You calculate your new score, you'll be able to see if you have 3.3 or 2 or 5 or 4 within the parameter. You could know that anything on a 3 on a single parameter needs to let the nurse in charge know immediately. Anything, and the hourlies you need to check, is it 3 hours, 2 hours, 1 hour? It varies. So you always have to keep accurate information and escalate. So this is where you're now going to identify your relevant skills. You know, earlier I said that the heart rate is 120. So this definitely will tell you that the patient need an ECG record checks due to cardia. ECG is electrocardiogram. So that's how you will start. You gather all your equipments, the 12 lead ECG, gather it, and when you gather it, you explain the procedure to the patient, reassure the patient, and also gain consent. What does that mean? It means that you have to explain the patient the rationale of what you are about to do. Example: hello, Mr. A. We've done an assessment on you, and we noticed that your heart rate is on the high side. Are you happy for me to do an ECG to check exactly what is happening within your body? Then you gain consent, because you have to take off the patient's clothes. So these are all important to know. And make sure that the patient is also on semi-recumbent bedside position, approximately 45 degrees. So then you now place one ECG on the internal part of each angle and your wrist. You have to avoid the bony point, that there is bone in when you open up your fingers down after your thumb. You see that there is bone there. Avoid it. Avoid it. Make sure you don't put it near the bone. Okay. So then you place the chest lead. Then the number one is the V1 is the fourth intercostal space, right sternal margin. These ones I have to show you on my next video so that you'll be able to see how it goes. Then the second one is the fourth intercostal space, left sternal margin, and the V4 is in the space in the fifth ICS, left mid clavicular line. Then the V3 goes in the middle between 4 and 2. 5 in the fifth intercostal space, left anterior axillary line. V6 is the fifth intercostal space, left mid axillary line. So I have to demonstrate this after this video. That will be my next video, so that you're able to understand exactly what I am saying. Then when you attach the lead to the electrode using the labels on the lead as a guide, you now check if the patient name, identity number is correctly input in the machine. Then you print your ECG. When you print this, you have to look carefully. This is the aspect that most people have problem. I personally had a little issue on this area because I was looking at the heart rate on the blood pressure machine and the dynamo, forgetting to read the one on the ECG paper. So the one on the dynamo was higher and the one on the ECG paper was normal sinus. So you could see that I was able to say that my one is tachy sinus. So it was wrong. So I had to lose little mark on this area. So be very careful. Although I was able to say that I have to give to the doctor for doctor to check and sign it off on my S-bar handover. So that was the early area I would like you to pay attention when you are about writing this exam. Then on your S-bar skills, S-bar, this is the tool we use to hand over, communicate within the team. And it's the situation, background, assessment, and recommendation. So all those your details you have got on your ECG. This is now the is a place where you are going to tell the doctor what is really happening with the patient. The situation, introduce yourself. I am nurse from surgical ward Then I have a patient who came in with sickness, admitted a few days ago, had a fall, and an assessment, you have done this, you have done that. You now list out all the things you have done on your A to E. Then you can now recommend to the doctor that you have done an ECG, that you need him to be here in 5 minutes to sign off the ECG and to check what things that need to be done. That's it. Then you are now going to talk about your leadership style and the situation. In my own case, I choose democratic leadership style because I have to work with other members of my colleague to carry out this task. They have to help me with the ECG machine. We have to get the lead. If we don't have it, everything was done accordingly. So that's all for now. I believe I'm able to guide you on this aspect, but on my other video I will be able to show you how I put the cuff on the hand and how I place the ECG machine. Thank you for watching. Like, support, and subscribe. Thank you.